Massaging the uterus every 15 minutes, it remains flaccid and the patient passes large clots. What does these signs indicate? This is uterine atony.
I said time's up. That's what I pushed up.
Good. That's as long as you know it. Doesn't matter how it affects your score for the game, but that's okay.
Okay.
So if the uterus isn't contracting, this is right after delivery, then it's uterine atony. And so the first thing to do is to massage it. What else would we do with uterine atony, do you think?
The Pitocin.
We can give Pitocin, okay, because Pitocin is a uterotonic to improve uterine tone, right? Make it contract. What else could we do?
Give fluids.
We give fluids because we're worried about the amount of bleeding she's having.
Right.
What else can we do to try to get the uterus to contract better?
Give medication.
What other medicines would we use besides Pitocin?
Oxytocin.
Okay,
Oh,
Pitocin, oxytocin are the same. Yep. What else?
I'm sorry.
No, you're good.
Cytotec. Or Metrogen, maybe? Okay.
Yep. And there's one more uterotonic. So there's Pitocin, Cytotec, Metrogen, and one other one.
None that starts with an N?
It starts with an H.
With an H. I'm blanking right now.
The other uterotonic.
Is it hydrolysines for BP?
Right. It's Hemabate is the other one.
Hemabate. I'm writing that down.
And because they don't remember if these are in the game, what's the contraindication for Metrogen?
You said a
contraindication. Like when would I not, if my patient's bleeding a whole bunch and we massaged the fundus and we gave Pitocin and the provider standing there and says, let's try Metrogen. What would be something that I'd say, actually, this is she has this condition, so we shouldn't give it.
Opioid addiction.
No.
No. Oh my gosh, it's on the tip of my tongue, but I can't think of it. Is it? It's not diabetes. It's not.
Metrogen is contraindicated with hypertension. And Hemabate is contraindicated with asthma. And so as the nurse, you're your patient's safety net. So in an emergency, if she's hemorrhaging and the provider doesn't know this patient very well and just walked in and is like, okay, let's try this. You say, okay, but she has this, or this is in her history or whatever, so that they can make the best decision for your patient. All right. During the postpartum period, the fundus of the uterus is expected to go down normally by about how many centimeters per day? Okay, usually 1 a day.
I was right between 1 and 2. And I was like, I feel like it shouldn't be 2 though.
Well, and I think that I've seen it say 1 to 2.
Yeah.
And so that's kind of the hard line, but I would stick with 1.
Okay.
Unless 1 isn't a choice, then I'd go 2. But typically, and 1 is easy, right? Because if you see something that says your patient is 2 weeks postpartum, and well, if she's 2 weeks postpartum, if it asks where you would expect to find the uterus, would you expect to find palpate a uterus 2 weeks postpartum, thinking about 1 centimeter a day?
No.
No, that's like 14 centimeters. That's like down to her knees. Well, it's not, but you know what I mean. When the uterus is firm and contracted, but there is still vaginal bleeding, what should the nurse suspect? All right, so if the uterus is firm, so if we see bleeding, the first thing we think is acne. But if we go to massage the fundus and the uterus is a nice, firm, contracted ball, then where's the bleeding coming from? And we're thinking maybe it's a laceration.
We just went over that yesterday.
Good. I did this in class yesterday too with my PN students. The nurse notes that the mother's temperature is 100.2 4 hours after delivery. What action would be most appropriate?
I was between those two too.
Okay, what were you thinking when you were between those two?
I was thinking, what's the only thing that I can do for this patient before notifying the physician? But then immediately I was thinking infection. So they should probably get there soon. But either way, I feel like I could have immediately been like, okay, let's go ahead and start some fluids just to get her hydrated. I don't know. I was thinking different, I guess.
No, I think that that's a great thought process.
I was like back and forth.
I was
Yeah.
that back and forth between A and D.
All right,
Yeah.
so let's talk about it for a second. A is the red, right? Retake the temp in 15.
Right.
Mhm.
Anything that delays care is not your answer. So retaking a temperature in 15 minutes is a delay, right? Because now I'm waiting 15 minutes before I do anything. All right. So that is a way to eliminate, if you're not sure of something, that's a way to eliminate one. Notify the physician. It depends on how concerned we are. Because here's what I'm going to tell you, and this is where you have to be able to have your knowledge base for this question, is that in the first 24 hours after delivery, it's not uncommon for a mom to have an increase in temperature because all these fluid shifts have happened and she's dehydrated. Okay. And the magic number that we're watching for is greater than 100.4. So in this question, she's less than 24 hours out. Her temp's less than 100.4. I think she's dehydrated.
Mm-hmm.
So encouraging fluids is the best choice for those reasons. But if you weren't sure, then Leighton's idea of what could I do for this patient first before I notify the physician makes a lot of sense. Because if you think about a lot of the scenarios that you guys get in your questions, there's things to do and then there's a notification. If it tells you in the question you've done stuff already, then you probably notify is probably your next choice. But if you haven't tried anything yet, because like think about like if your heart tones are down, you should turn the patient before you notify. If she's bleeding, you should massage the fundus before you notify. And so you should do something first so you're not just letting that condition simmer that you're worried about while you're on the phone with the doc. In this case, if you're not sure and you're worried and you do want to notify the doc, then maybe do something first so you can say, so this is what I'm seeing. This is what I've done so far. What would you like? Okay.
That makes
Okay. That makes sense.
And then down here, document the findings. Document the findings if your assessment is normal. So if it says the mother's temperature is 98.24 hours after delivery, what action is the most appropriate? document the findings would be the best choice. Okay.
Okay.
The nurse notes that the lochia is red and has a foul-smelling odor on a 1-day postpartum patient. The nurse determines this is what?
Oh, I thought we're supposed to be the lochia rubra or whatever.
Okay, so lochia rubra is normal for 1-day postpartum. What's the concern on this statement?
The odor.
Mm-hmm. The odor is the concern. The lochia is normal, being red. I would expect red, but I wouldn't expect an odor. The nurse is monitoring a postpartum woman who had epidural anesthesia and for a vulvar hematoma. Which finding would best indicate that she has a vulvar hematoma? Okay. So a hematoma is what?
Bruce.
Yes, it will eventually look like a bruise, but what is causing it?
The blood pooling
blood.
under the skin.
Yeah.
Okay. Yeah, so you have a collection of blood in the tissue. And usually, guys, if she has this, it hurts. And so these both red and blue, complaints of a tearing sensation and complaints of intense pain is probably what you would see. Okay. However, in this question, it said she had an epidural. So right now, she's not feeling it yet. So then you have to think, okay, if she's not feeling pain because she had an epidural, what else might I see? And this can be a hemorrhage. She could be losing a lot of blood into that area. And so then what I'm worried about is is changes in vital signs. What's the first vital sign change we see with hemorrhage, typically with hypovolemic stuff?
Blood pressure drop.
Before that,
Heart rate or
heart rate first. Yeah, heart rate goes up even before the blood pressure starts to go down, typically, because as we're becoming more volume depleted, the heart is pumping faster to circulate what's left. And then, so the heart rate goes up and then the blood pressure starts to go down. So if I'm having a patient who is postpartum, she's hanging out, she's still numb from her epidural, and I'm noticing she's becoming tachycardic. Even if I'm noticing she's becoming hypotensive, these are changes for her. Let's figure out why. Okay. And so with this, I'm not seeing blood on a pad because the blood is contained in the hematoma.
Right.
So the change in vital signs would be the next thing to see. I actually had a patient that was bleeding, and it was an internal bleed. Her hematoma was in the abdominal wall, which is ridiculous. And the first thing we saw was tachycardia. And I was like, that's weird. Why is her heart rate up? And my nurse brain was like, she's bleeding from somewhere, but everything looked normal. She was feeling fine. So notify and reassess. And now the blood pressure's low. And then it just spiraled from there. It was really, really a lot.
Mm-hmm.
So vital sign changes first. And so if you have a patient who's got an epidural and she's sitting there comfortably holding her baby and you're seeing these vital sign changes, your nurse brain has to go, something's not right. Nadij, you can still play. The pin is here at the bottom. And so you can go to Kahoot.it on your phone and type in this game pin. We're not very far in. We've been chatting a lot.
Mm-hmm.
Methergin is ordered to treat postpartum hemorrhage. Before administration, the priority assessment is to check what? Yes, good. We talked about this, right?
Yes.
Good job. I almost said, oh, we discussed this already, but I thought, well, we'll see if you remember. Which of the following findings would be expected when assessing the postpartum client?
Oh, I was between those two.
Yeah.
All right, let's see.
I feel like the green one that I just clicked is bad. I think that's not supposed, or no, that's before birth. I think it's up because the bladder,
Mhm,
excuse me, because the bladder is pushing it over there.
right. And that would be concerning and
Right.
increase her risk of uterine atony. So the fact that it's up and to the right is exactly what you said. That's a sign of bladder distension.
Okay. So I was thinking about it opposite.
Okay. So where do we expect to find the fundus on right after delivery?
1 centimeter above.
So really close to it. Okay, so right around the belly button. And there's and if it's a centimeter above or centimeter below, I think that's totally fine, because that also there's a little bit of subjectivity to this because of maternal habitus. Like if she has a high BMI, that's going to change where we find her fundus in relation to her umbilicus. And also there's other factors. So right anywhere close to the belly button in that first initial postpartum period is going to be pretty normal. So 1 centimeter above at the, or we'll say at the U for the umbilicus, or 1 below would be, I would be not worried. So this 1 centimeter above at 1 hour sounds good to me. Blue says 1 centimeter above on postpartum day 3. Now think about that other question and how much it's supposed to go down per day. And where would we expect to find the fundus on postpartum day 3?
2
3 centimeters.
So if we're still using the belly button as our landmark, I'd say 3 finger widths or 3 centimeters below. Fundus palpable in the abdomen at 2 weeks postpartum. No,
You didn't find it.
you shouldn't find it. If I can palpate a fundus at 2 weeks postpartum, what condition does that patient have?
I know that one.
I have no idea. I'm sorry.
Okay, so what is it when the uterus returns back to its pre-pregnant state? This that we're talking about where it goes down a centimeter a day. What is that called? That's involution. If it doesn't do that, it's subinvolution.
The subinvolution.
And what's that, Caprice? What did you say?
That was one of my NCLEX questions.
Yeah. And so subinvolution is the failure of the uterus to return to its pre-pregnant state. Why? Why is it not returning? And usually there's 2 main things that cause this. Do you guys know what causes subinvolution?
Something was left behind.
Retained placental fragments. The other one is endometritis. So if the endometrium is infected, or if there's retained placental fragments, those are the two main things that cause subinvolution. But if the uterus isn't contracting down and returning to its pre-pregnant state, that is going to be a big cause of our late postpartum hemorrhage. So a patient that bleeds after the first 24 hours. In the first 24 hours, that's early postpartum hemorrhage. That's uterine atony. That's the 4 medications we talked about. That's the IV fluid and maybe blood products and all that. But any bleeding that happens after that is subinvolution. And a uterus isn't returning to its pre-pregnant state. Something's in there keeping it from contracting. If at 2 weeks I can palpate a fundus, she has subinvolution. So we got to figure out why. Okay.
Okay.
What should the nurse's first action be when postpartum hemorrhage from uterine atony is suspected?
Oh, I didn't get a chance to answer.
Me either.
Okay.
I feel like I read for too long.
All right. Well, and all the answers were long. Why now we know the answer is blue. So let's think about why. So red says teach the patient to massage the abdomen and go get help. Are we doing that?
No.
No.
We'll talk about blue in a minute since it's the right answer. Start IV fluid to prevent hypovolemia and notify the healthcare provider.
You're not doing that
Why not?
because isn't she already on an IV?
I don't know. That would be making an assumption. That's not in the question.
I don't
Okay.
know. I was between blue and yellow while I was reading.
Okay.
I was like, okay, maybe this one, but also maybe this one.
So we'll come back to that one. Green, ask the patient to void and reassess fundal tone and location.
No. You would think that the patient would void, but
All right. So, okay. All right. So, begin massaging the fundus while another person notifies the physician. So let's think about what's happening here. We have a postpartum hemorrhage from uterine atony. Sorry, guys, I have to take my hoodie off. We have a postpartum hemorrhage from uterine atony. So uterine atony means uterus isn't contracting well. And she's bleeding because it says postpartum hemorrhage. Okay. What are the things that needs to happen?
the uterus needs to start contracting.
Yes. The uterus needs to start contracting. So the first thing to do is to encourage the muscle to contract, which is what massaging the fundus is going to do. Okay. But there's other things we can consider. The bladder is a consideration because if the bladder is full and pushing up on the uterus, then it can decrease the contractility of the uterus. But that's not the first thing. Okay. Also, giving her fluid is a good idea because she's hemorrhaging, except it's not addressing the fact that the bleeding's happening. It's not trying to stop the bleeding. It's like a reactionary response, like, oh, we're losing volume. Here, have more volume, instead of fixing the problem. So truly, we should probably manage her bladder. We should probably give her fluids, but those aren't the first things to do. The first things to do is to get the uterus to contract, and so massaging the fundus is going to be the first thing to do. Okay, so truly, like in this situation, in this emergency, if I go in to check my patient, she just had her baby, and I go to check her belly and her bleeding, or better yet, let's not even say that. Let's say I stepped out and her blood pressure cuff goes off and it alarms that she's tachycardic at the desk, or it alarms that she's hypotensive at the desk. I already have a sense that either she's got her arm bent because she's breastfeeding or I'm walking into a mess, right? So go in, and the first thing I want to do is assess her bleeding. And if I assess that she's bleeding, the first thing to do is massage the uterus. Is it firm? Is that where the bleed? Is it uterine atony? And in this question, it says uterine atony. So I need to massage the uterus to make it contract, and I need to have a friend call the doc because I'm going to need orders for all those medicines we talked about if massage doesn't fix the problem. Okay, so massaging the fundus, and then I would manage the bladder. So the next thing I would do is I would probably, if there's a lot of bleeding happening, I probably would have friends come. I would pull my light and have a lot of people. Then one person can stay massaging the fundus while another one is putting in a Foley, while another one is hanging Pitocin.
That makes sense.
Okay. So massaging the fundus is going to be the first thing to do. We got to get the muscle to contract. The nurse notes a boggy uterus, the fundus above the umbilicus, and deviated to the side. What should the nurse assess next? If the fundus is above the umbilicus and the uterus is boggy and is deviated from midline, those are all classic telltale signs of a full bladder.
I wonder.
A full bladder is going to decrease the contractility of the uterus and cause bleeding.
Right.
Massage and breastfeeding have been ineffective to control a boggy uterus. What order will the nurse anticipate?
Oh my gosh, I was literally between those two, and I was like, well, we don't want it to contract on top of the uterus, but then at the same time, you want it to go down. Oh my gosh, I was so back and forth.
Okay, so massage and breastfeeding have been ineffective for controlling the boggy uterus. So oxytocin will be the medicine here to help the uterus contract. Magnesium sulfate actually decreases the contractility of the uterus. So your patient that's on magnesium sulfate for preeclampsia has a higher risk of having a postpartum hemorrhage because of that. Why in this question, when it says massage and breastfeeding have been ineffective, why was breastfeeding even considered to help the uterus contract?
Because breastfeeding stimulates the uterus to start contracting.
How does it do that?
It sends signals and releases the hormone. What's the hormone? It's not, is it prolactin?
Prolactin is going to tell the breast to fill with milk.
Okay.
And it doesn't do anything for the uterus. What's
Right.
the one that tells the breast to empty?
Oxytocin?
It is oxytocin. Yep. So oxytocin, when she breastfeeds, it causes the body to release its own oxytocin, which in turn can help the uterus contract.
The 17 seconds is messing me up.
A 4-week postpartum patient with mastitis asked the nurse if she can continue to breastfeed. What is the nurse's response? So she can breastfeed. And we
Wouldn't it be
actually
difficult?
encourage her to. What's that?
Wouldn't that be difficult?
So that's going to be the thing. Okay. So she can breastfeed with mastitis, but with mastitis, it's painful. So we want her to still breastfeed if she can, but we can encourage her to latch the baby on the unaffected side first when the baby's really ravenous, and then offer the the affected breast second. She can also gently pump the affected breasts to help. We want it to still continue to drain. We don't want it to be full and engorged. So the other thing too is if she like takes a warm shower right before she breastfeeds, or she uses some warm compresses on her breast, that's going to help the milk let down. So those are all things she can do, but definitely breastfeeding still can continue, and we encourage it too if she can manage it, even though it's uncomfortable. A woman had a vaginal delivery 2 days ago and is preparing for discharge. What will the nurse teach the woman to report?
Oh,
Okay, so why would we want her to report a fever?
because you said only 24 hours. Is it normal?
If
I
it's
just heard
less than 24 hours, then and it's less than 100.4, that's normal. But outside of that, it's cause it for concern. Yep. A patient complains of a reddened area on her lower leg. Her temp is 99.8. She has rust-colored lochia and sore breasts. What is the nurse going to suspect? Okay, so 99.8. Am I worried about that temp?
No.
No, so I'm probably not thinking infection. Because if she had a puerperal infection, she had mastitis, we would probably see that temp greater than 100.4. Rust colored lochia, it's just a shade of red. It's like reddish, has a little bit of an orange look to it, but that can still be a variation of lochia rubra, and it could be starting to transition to serosa. So I'm not worried about her bleeding. Sore breasts, it's talking about both of them, and it's not clear, so she could be engorged. It doesn't say like sore nipples, this is sore breast, so it could be engorgement, it could be a lot of things, so I'm not necessarily honing in on that either. But this reddened area on her lower leg, that could be a thrombophlebitis. And so that would be, based on the scenario, that would be the first thing that I would investigate, is the area on her leg.
Okay.
Which statement indicates to the nurse that a postpartum patient understands the signs of late postpartum hemorrhage? Okay.
I'll understand. Oh my gosh, I keep reading wrong. I did that on an exam in med-surg as well. I read it the opposite. It asked what was appropriate, and I answered all what was not appropriate.
Oh no. Yeah, so taking the time to read it is gonna help, right? And understanding what it's asking you. So discharge that changes to red after it's been pink or white is a very classic sign of late postpartum hemorrhage. And so remember that late postpartum hemorrhage is also going to be in that same family as subinvolution. So a uterus that is supposed to be contracting down to its pre-pregnant state isn't. And so the lochia is supposed to go rubra, serosa, alba, but if it goes rubra, serosa, rubra, that's a sign of a late postpartum hemorrhage. So after the first 24 hours, if we've moved beyond rubra and then gone back to rubra, that's a sign.
Okay. I was so upset too. We were going over an exam yesterday and I saw that. Like, oh, I'm so upset.
Yeah. This has to do with mastitis and understanding treatment instructions. Warm shower before nursing the baby.
I was looking at the red one and I was like, nope, it's not cold.
So there's a time and a place for both. So warm before nursing the baby is great for women with mastitis, especially. And truly, warmth before feeding is always going to help the breast empty, even if she doesn't have mastitis. Cold is good, like for women with engorgement, when the milk first comes in and the breasts are feeling really full and uncomfortable, then cold between feedings helps with inflammation. So warmth is going to help the breast empty. Cold is going to help with inflammation. So just kind of the timing on that. So for your woman with mastitis, taking a warm shower before she feeds her baby is great. Not only is that going to help the breast empty, but it also then helps the breast be clean. And she's already got an infection with mastitis, so. The best response for a woman who tells the nurse she feels tired and sick all the time since I had my baby 3 months ago. Hey, what do you think's happening with this mom?
Baby blues.
Do you think baby blues, because she had her baby 3 months ago?
What's the step further? It's not depression, it's the, well, maybe it is depression, but that's kind of far out. I can't think of the word off the top of my head.
So in the first 10 days, it's probably baby blues. If the symptoms are worsening and continuing past 2 weeks, we're worried about postpartum depression. And postpartum depression can linger for a long time. And typically they really need help. They need to see a therapist. They might need medication. And then the worst one is psychosis. And with psychosis, that's when we get the really bizarre behavior. They can have like auditory hallucinations. They can have delusions. Those are going to be when we worry about infanticide and suicide, is with psychosis. For this mom, she had her baby 3 months ago and she's feeling tired and sick all the time. I'm worried about postpartum depression for her. And so she would benefit from probably talking to her care provider, and then they can give her resources or talk about medications and things like that to help her. Olivia, we have 11 more questions. So you can stay.
Yeah, I would love to stay. I'm sorry. I looked at that and it just dawned on me Eastern time.
We
And
discussed this before, but at the beginning of the game too, that a lot of students get confused with the time zone.
Yes, because I was sitting here and I thought I just told my friend, like, I'm gonna be there, I'm gonna be on time, like ready. And then here I looked at our email. I just started checking emails and looked at it and I was like, Eastern time. I'm so sorry.
That's okay. So we've been really taking our time with this game. So we still have a lot to go. So you can actually play still. You can go to Kahoot.it on your phone, and then the game pin is right down here at the bottom.
What about if I'm on Zoom on my phone, will I still be able to do Kahoot as well?
If you are on Zoom on your phone and you try to play Kahoot on your phone, you won't be able to see both at the same time. So you can just listen and chime in and stuff. That's fine.
Okay.
All right. For a woman who had a cesarean birth yesterday, what action is most important to prevent thrombus formation?
Square.
Square. Ambulation. Why do you think ambulation is going to help prevent thrombus formation?
Because it gets things circulating. It gets you going. And with it circulating, there's no time for clots.
There you go. There's no time for clots. I love it. 5 days after vaginal delivery, a woman comes in for a fever and persistent cramping. What is the possible cause? So remember dehydration in the first 24 hours. She's
Okay.
five. So in the first 24 hours, if we have an increased temp, but still usually less than 100.4, she's probably dehydrated from having a baby. After that, if we have a fever, then we're worried about infection. And for this patient, she's having persistent cramping. So now I'm thinking about, well, abdominal tenderness and cramping, something's happening maybe in her uterus. And so endometritis is the infection of the endometrium, which is the lining of the uterus. What else might we see for this patient if she has endometritis?
Bleeding? Maybe
We might.
Oh.
We might see bleeding because we might see subinvolution.
Is this the one with the dark red blood if we see bleeding?
Well, if we're seeing bleeding and we're thinking about dark blood versus bright red blood, that's typically when she's pregnant and we're thinking about the difference between our placenta previa and our placental abruption. So this one, the game we're playing right now is all postpartum. So she's not pregnant anymore.
Got it.
Yeah, I know you didn't know that part. But if she has an infection in the uterus, the other thing that I was thinking we might see is that foul smelling discharge. So
Infection, right. Okay.
After prolonged labor, a woman vaginally delivers a 10-pound, 3-ounce infant. What complications should the nurse assess for?
Circle.
So I didn't even
Really?
read the answers, and I was like, she's gonna have a postpartum hemorrhage because her baby was huge. All right, so cervical laceration, actually maybe, right? So with this, the cervix is what gets torn. This is where the laceration is. The question was really wanting you to pull out the fact though that this baby was big. So now we're also thinking about hematomas. But I could see their answer actually.
So why is
So
it?
I was
why
just
is it
about to
better
say, so
to-
what's the difference? Why would I choose hematoma instead of a laceration? Like what's gonna make me know the difference?
Well, because so the hematoma, the patient is going to have a higher risk of a hematoma or a vaginal laceration because that the baby was 10 pounds. Cervical lacerations more often happen like with like a precipitous delivery where the baby's coming down and through the cervix so fast it can tear the cervix. We don't often see cervical lacerations for a prolonged labor. And so for this one, we had a prolonged labor. She had this huge kid. So now I'm thinking tissue trauma. So I'm thinking about hematomas. I'm thinking about lacerations, but I'm thinking about lacerations in the vagina.
So laceration would be more for if there's the baby's coming out really fast.
For on the
Not
cervix.
Not necessarily the size of the baby. That part you're more worried about a hematoma.
Yeah.
Okay.
Okay, so size for hematoma and the actual speed for laceration.
Pretty much, yes.
Okay.
Kinda.
Yeah, there's
sorta.
exceptions all the time.
Right.
And so what I would say, guys, is I would think about hematomas and lacerations for both. And then if you had to tease it out and break it down, like this question actually included it this way, then evaluate it further. But for the most part, if they have a precipitous labor or if they have a big baby, I'm thinking tissue trauma. I'm thinking about lacerations and hematomas for either of them. But when it said specifically a cervical laceration, I'm less thinking about a cervical laceration for this prolonged labor. For this girl with this big kid, I'm thinking hematoma.
Okay.
But most of the time, like if you saw this question, I think it wouldn't give you both. It would give you like endometritis, retained placental fragments, and I don't know, some other random thing, and not have lacerations and hematomas as two different answers.
Mhm.
Most of the time, I don't think it would ask you to tease it out.
Okay.
A postpartum patient has lochia rubra times 2 weeks and pelvic discomfort. What's the usual treatment for subinvolution?
For subinvolution is just,
Go ahead. You can still say what you were going to say just because it timed out.
I was just thinking subinvolution is just when it doesn't contract. So we want to, but they chose the green one, and I was thinking the oxytocin because we wanted to go back down.
Okay.
That's why I put it, yeah.
Yeah, and we do want it to go back down. So subinvolution, so she's had rubra for 2 weeks. So the uterus is not contracting down to its pre-pregnant state.
Mhm.
But oxytocin, if I give her oxytocin, encourage the uterus to contract, it's not going to fix the problem. Because remember, guys, what is usually the cause of subinvolution?
Something was left behind or infection.
Okay, so retained placental fragments are infection. And so if there's retained
Get rid of the whole thing.
if there's placental fragments in there, they're going to have to go in and get them out.
Okay. That makes sense.
So that's dilation and curettage. They actually dilate the cervix so they can go into the uterus and clean out the retained placental fragments.
Mm-hmm.
Because we can give her oxytocin and make the uterus contract, but if those fragments are still in there, it doesn't fix the problem.
Mm-hmm.
Makes sense.
It's neck and neck, folks. 1 day postpartum patient has elevated temp, cough, and slight shortness of breath. What action should be implemented for her? Well, this one we're most worried about a PE for. Okay, so remember that pregnant women are hypercoagulable. So they still are hypercoagulable in the postpartum period as well. And so if we have this sudden onset of shortness of breath and a cough, we're worried about a PE. And maybe it's not that, but that's the first thing we should rule out, because that's the most dangerous one. And sometimes in OB, and I feel like in all areas of healthcare, we rule out the most dangerous things first and then go, okay, well, then maybe we're not worried. We don't know what it is, but we know it's not dangerous. Vaginal delivery yesterday has a firm uterine fundus and a trickle of bright red blood. How's the nurse to react and respond?
Triangle.
Triangle. Okay, so the uterus is firm, but we're still seeing bleeding. So now I'm thinking laceration. The nurse assesses a positive Homan sign when the foot is sharply dorsiflexed. What does the patient, where does the patient report the pain?
Where?
Oh crap. Think I pushed. Yeah, I knew that.
All right, what's when the Homan sign, guys, actually is not something that we encourage nurses to do anymore. But you do still see it like in practice for nurses that have done it for years. What is it an indication of?
A clot?
So it's a way to assess for a DVT. So we flex the foot up, and if they get pain in the calf, then that is an indication that they might have a DVT. So why are we not using Homan sign anymore? Why are they discouraging this?
Is it because of the epidurals?
Not quite. Think about if we're to do the Homan sign, we have to flex the foot up. If
Right.
there's a clot in the calf, then we risk dislodging the clot by doing the assessment. And then we have a bigger problem because then she can have a PE. So we're actually moving away from doing Homan sign, but it's still important to know what it signifies. The mother who had a vaginal delivery yesterday has a white blood cell count of 30,000. What action should be implemented?
Trying.
Hey, what do you think if the white blood cell count is that high?
Infection.
You're
or
thinking infection.
It's bad, very bad.
Okay, so the white blood cell count can go up right after delivery and during labor because it's an inflammatory response in the body. But that is pretty high. But that by itself, we need more information. So we are thinking infection. So let's assess. What kind of infections might we see in the postpartum period?
Endometriitis.
Yeah.
What's
So
Do you have
endometriitis is the most
mastitis?
common one. What else might we see?
Mastitis?
Mhm.
Or the what was the other? Phlebitis?
Okay, yeah, I mean, we could see phlebitis
Maybe.
also. We could see if she had a laceration or if she had an incision, if she was C-section, we could see infection at any of those sites. UTI also. So we need to assess further and say, okay, so I'm worried she has an infection. Let's take her temperature. Let's ask if she's having any pain or tenderness anywhere. Let's see if we have any foul smelling drainage or discharge. Like, let's get more assessment and then we can decide what to do. So this is just one piece of the puzzle.
Professor?
Mhm.
How when
What's that?
when you say assess and she just had the delivery yesterday, how does
Yep.
she have an infection without us picking up on it prior to that?
Well, so it's the most if she just delivered yesterday, and I don't remember if it said it was yesterday, but if it was just yesterday, truly it's probably not mastitis, right? Because we haven't really gotten that far into breastfeeding. I do think though some people can get mastitis anyway. The most common one would be endometritis. And so if she had chorioamnionitis in pregnancy, then there's already bacteria in there. So then we could be seeing signs of endometritis because that's the infection of the lining of the uterus.
Okay, thank you.
Yeah. A postpartum patient experiences anaphylactic shock. What is the most likely cause? Okay, anaphylaxis happens with an
Oh.
allergy.
Oh my goodness. Silly me.
A woman's prescribed Coumadin to treat a DVT. What will the nurse instruct as the antidote for warfarin overdose?
Square.
Okay, so vitamin K is the antidote for this. Now, when that we almost never have to give this in OB to a pregnant woman or postpartum woman. When do we normally give vitamin K in OB?
To the baby.
We give
in
it to the
their eye.
baby. Yep. So it's one of the medicines we give to babies when they're newborn because it helps promote the production of clotting factors for the baby. But if you have a woman that has a warfarin overdose, then we would give it for her too. A perineal pad on a 3-hour post-delivery patient has no lochia. Which finding would the nurse expect on assessment?
Come
Is
on.
it circle? Oh.
So,
Damn it.
so the idea behind this is if there's nothing on the pad, there's probably a clot in there because you should be having some lochia, even if it's just a little bit. If there's a clot sitting in front of the cervix, it's keeping anything from draining. And so then we also have signs of hemorrhage, like a soft, boggy uterus.
I started
Okay.
picking.
Yay.
Yay.
Yay. Just waking up for real.